Hi everyone, welcome back to Next Level Ophthalmology. Class 4 today we'll be dealing with pupil, a very important topic as per your clinics are concerned, and also many questions come from pupil with respect to the light reflex pathway in your theory exam. Okay, it can be a little confusing, so pay attention. The pupil is usually a single, almost central aperture within the iris. So it's a very dynamic structure. It's never still. It's always in a state of constriction and relaxation. And why is it so? Because it's controlled by the sympathetic and the parasympathetic systems. So there is always a continuous balance between these two systems, causing the pupil to have a very dynamic state. So the pupillary reflexes include light reflex and the near reflex. So let us learn some terminology related to the pupil. What is meiosis? Meiosis means a small pupil. So to know what a small and a large pupil is, you should know that the normal pupillary size is from 2 mm to 6 mm. So anything less than 2 will be meiosis. So mydriasis is a large pupil that is more than 6 mm. What is anisocoria? So understand that cor means pupil, an means not, iso means same. So pupils of different sizes is called anisocoria. What is polychoria? Multiple pupil. Cor, ectopia, in the sense the pupil is ectopic. Hippus. What is hippus? Hippus is also known as pupillary unrest. There is alternate constriction and dilatation of pupil. It may be physiological, but it can also indicate severe neuronal degeneration. What is APD or RAPD? It's a defective afferent pathway, afferent pupillary defect, or relative afferent pupillary defect. We are going to use these abbreviations very commonly in the next few minutes. What is an EPD? EPD is an efferent pathway defect. Okay. So normal size of the pupil 2 to 6 mm. What are the causes of meiosis? Physiological cause in very small babies and aged individuals. Acute iridocyclitis, Horner syndrome, Argyll-Robertson pupil, use of myotics, and pontine hemorrhage. Causes of mydriasis, blunt trauma causing sphincter tears. Third nerve palsy, Edie's pupil, use of mydriatics and atropine. So let's now understand the pupillary light reflex. So let's start from here. There is a light source illuminating the retina. Then the impulses flow through the optic nerve here. And then there is a decussation at the chiasm. These fibers travel along the optic tract along with the fibers of the visual pathway. And then instead of going to the lateral geniculate body, they take a detour towards the pretectal nucleus in the midbrain here. Okay. So when light is shown in one eye, the fibers reaching both sides of the pretectal nucleus. Next, from the efferent, till here was the afferent limb. From here starts the efferent limb. So from each pretectal nucleus, you get two sets of fibers going to the Edinger-Westphal nucleus bilaterally. So this is known as double decussation. One decussation happens here and one decussation happens here. So this is the cause why we get a consensual light reflex in the other eye. So what happens after this? From the Edinger-Westphal nucleus, you get preganglionic fibers that travel along the inferior division of the third nerve like this and reach up to the ciliary ganglion. In the ciliary ganglion, there is a relay, and then after that fibers form the postganglionic nerves and they end in the sphincter pupillae of both sides. So whenever light is shown on one eye, there is bilateral pupillary constriction. So this is the normal pupillary reflex. So what is near reflex? Near reflex includes convergence, accommodation, and pupillary constriction. So these are the three parts of neuroflex. What is convergence reflex? When the eyes come closer in an attempt to bring the object in line with the line of the vision. So what happens here? The efferents probably begin in the bilateral medial recti when there is an effort to converge and focus the object. These impulses travel along the third nerve to reach the mesencephalic nucleus and the convergence center in the pretectal area. Again, the efferent fibers follow the pupillary light reflex pathway. How about accommodation? How is it established? The efferent travels mostly from the retina, okay, and they go along the visual pathway to the parastriate cortex. From the neurons travel from the parastriate cortex to the Edinger-Westphal nucleus. So impulses travel along the third nerve to reach the sphincter pupillae as previously described. So efferent, if you see, it's almost the same for all the three pathways except the efferent in which the light reflex follows the optic tract, pretectal nucleus, Edinger-Westphal nucleus. In convergence pathway, the efferents begin from the medial recti. There is no involvement of the optic nerve whatsoever. So the visual pathway is not at all involved in convergence reflex. So the ability to converge will happen even if the patient is blind. So this is the point you have to note here. But accommodation may be difficult because the visual pathway is involved. So what is light near dissociation? There is a presence of near reflex in the absence of a pupillary light reaction. So the converse can never be seen, and please never get confused. What are the causes for these? Bilateral RAPD, in the sense there is no vision in both eyes. So obviously there will be no light reflex, but there will be an intact accommodation or a near reflex. So bilateral RAPD or APD. Dorsal midbrain syndrome of Perinode. It's usually caused due to pinealomas in which there is affection of the dorsal midbrain. It is characterized by 4 points. First is lid retraction, also known as Collier's sign, in which there is a preference for the eyes to look down. Vertical gaze palsy, usually the up gaze is affected. The patient is not able to look up. Convergence retraction nystagmus. Here there is an excessive convergence due to loss of inhibitory signals from the third nerve, to the third nerve. Excessive convergence associated with the retraction of the eyeballs due to simultaneous contraction of the superior rectus and the inferior rectus, along with a downbeat nystagmus. And then finally there is a light near dissociation. Along the efferent pathway, lesions that can cause light near dissociation are the Argyll-Robertson pupil. I will explain you the features of this in the next slide. And then there is aberrant regeneration of the third nerve palsy. So the Argyll-Robertson pupil was originally described for which disease? So this is a repetition now. It was described way back in the late 1800s, and it was known as the prostitute's pupil because it was observed in tertiary syphilis or Tabes dorsalis. The Argyll-Robertson pupil, remember, accommodation reflex present. Argyll-Robertson pupil, you can easily remember it as a cause for light near dissociation. Usually it is a bilateral condition, okay, and the affected pupils are smaller in size, which, see, if you see here, the pupils do not react to light, whereas when you do an accommodation test or a convergence test, you see that the pupils are reacting. There are other causes like diabetes mellitus, which is more common, chronic alcoholism, multiple sclerosis, and Lyme's disease. But initially it was described in reference to neurosyphilis. So let's learn about the efferent pupillary defect. So when it is relative, in the sense it is a little less than the other, we call it RAPD. When it's totally absent, we call it APD. Okay, so we can grade RAPD based on how the pupil behaves. So grade 1 will be the abnormal eye pupil contracts weakly and then dilates. So there is some constriction. Okay, in grade 2, there is no constriction, the abnormal eye stalls and initially, and then it dilates. Okay, grade 3 is there is immediate pupillary dilatation, in the sense there is no conduction at all. So why should a pupil dilate when you're shining light on the eye? Is it a normal reflex? No. So let us have this diagram again. Okay, so here if you see, when you shine the light on the right eye, okay, maybe the efferent is a little damaged here, not fully. So the pupillary constriction is around 4 mm. In the sense, from 5 mm it's coming to 4 mm, not constricting fully. The same happens to the left eye. When you're shining the right eye, you know about the consensual reflex now. So you will see the pupil of the left eye also becomes 4 mm. Now you bring your torch to the left eye. Okay, when you're shining the light on the left eye, the efferent is fully normal, right? So the amount of constriction is a little more, correct? So the pupil becomes 3 mm from 4 mm. But when you get the torch back to the right eye, which is the affected eye, the pupillary constriction is only 4 mm. So it looks like it is dilating. So it is an apparent defect. It's an apparent pupillary dilatation when you bring the torch from the normal eye to the eye with affected efferent system. So this is what I've explained here. You're shining the light on the right eye, the pupil is so much bigger. And when you're shining the light on the left eye, the pupil starts constricting. So this is RAPD. So if you observe at any point in time between the right and the left eye, there is no difference between the pupillary size. So there is never anisocoria. Okay, so anisocoria is never seen in RAPD. So what are the causes of RAPD? Let us remember, in the retina, central retinal artery occlusion or venous occlusion, ocular ischemic syndrome, a huge retinal detachment, severe macular degeneration, and anything that affects the retinal function to a great extent, like a huge CME retinitis. So these are some common causes of RAPD in the retina. What happens in the optic nerve? Any kind of optic neuropathy. We have discussed in the second class, the optic nerve functions are affected in any type of optic neuropathy. So you can list all those causes here. Then lesions of the optic chiasm and the optic tract. This also we have discussed in the previous class. Lesions post the LGB do not cause any RAPD because the pupillary fibers have left from there. So causes of optic chiasm and optic tract dysfunction can give you RAPD. Then up till pretectal nucleus, if there are lesions like we discussed, ischemic lesions, trauma and neoplasia, you can get RAPD. So here is a small question here. So recognize the pupillary pathology from the results of a swinging flashlight test as depicted below. So they're saying that the pupil size on the right side when you shine light on the right eye is 4, and you shine on the left eye is also 4. When you bring the light to the left eye, pupil sizes are smaller. So this is what we just discussed. There is no anisocoria, so there is no EPD. So look for EPD in your answers and strike it off. So when you shine light on which eye the pupil is bigger, that is the culprit. So here the culprit is the right eye. So the answer here would be right RAPD. I hope it is clear to you. When looking for RAPD, look for the eye in which the pupil is bigger when you shine the light on that particular eye. Okay. So in left RAPD, what happens when light is swung from the right eye to the left eye? Again, the same thing. When you shine the light from the normal to the abnormal eye, what should happen? There should be an apparent dilatation. So dilatation of the left pupil only? No. So this pupillary reaction is always bilateral. Dilatation of the left and the right pupil? Okay. Dilatation of the right pupil only? No. The left should also dilate. So this is not the right answer. Constriction of the right eye and the dilatation of the left pupil. So this can also never happen. So the right answer here is B. So when you swing the light from the normal eye to the abnormal eye, both pupils will dilate. All of the following are causes for light near dissociation except. So again we have discussed all this. So the answer here would be unilateral RAPD. Okay, so why do we say that? We say that because if you shine the light on the right eye, okay, suppose the right eye is not working well, the right afferent pathway is not working well, there will be a constriction of mild amount of constriction in both eyes. But what happens when you shine the light on the left eye, which is normal? There will be a constriction, so there is light reflex. You cannot say that light reflex is absent, but the near reflex is always present. So in all these cases there can be light near dissociation, but in unilateral RAPD there is no light near dissociation, because light reflex is still present because of the normal eye being having normal conduction. All of the following are prerequisites for a swinging flashlight test. So let me tell you a few things about swinging flashlight test. It's a very useful test in picking up RAPD. It's usually performed in a semi-dark room with the patient facing forward and you standing on either the left or the right side of the patient and not blocking his view. And you have to ask the patient to look straight at a target and shine the light from the same quadrant in both eyes. In the sense, if you're shining the light from the temporal aspect in the right eye, make sure you do the same in the left eye. So never bring the source of light in front of the patient, because you might induce some amount of convergence and the amount of pupillary dilatation may be more, or you might think it is a light reflex when you're actually eliciting a convergence reflex. So the right answer here would be dark room. You do not require a completely dark room, you require a semi-dark or mesopic conditions. So how do you swing the light from one eye to the other? How long do you keep it? The light is kept for around 2 to 3 seconds on each eye, and the torch is moved briskly to the other side by not bringing the torch in the field of view of the patient. All of the following are causes of RAPD except optic atrophy, dense cataract, large retinal detachment, lesion of the optic tract. So the answer here is dense cataract. Why is this important? We see so many dense cataracts in our OPD, and then whether we cannot see the fundus, and so we cannot really say the retina is normal. So pupil is one of the very important signs that we rely on. So presence of an RAPD will tell us that there is something going on. So a cataract can never cause an RAPD. Please remember that even if it's a hypermature Morganian cataract, there cannot be an RAPD. So the right answer here is dense cataract. So let's move on to efferent pupillary defect now. It is characterized by absence of both the light reflex and the near reflex. Both the effects are gone. Both the reflexes are gone. Okay. So if you shine the light on the right eye, the right is not constricting, but the left is constricting. Why? Because the efferent pathway to the midbrain and the efferent pathway from the midbrain to the left eye is working. So from the midbrain to the right eye, not working. Right? So what happens when you're shining light on the left eye? The efferent pathway is working. Midbrain is okay, but the efferent pathway to the right eye is not working. The efferent pathway to the left eye is working. So again the pupil here constricts and here it doesn't constrict. So between the right and the left eye you see difference in size of the pupil, and anisocoria is always there. So anisocoria is a hallmark of EPD. The same thing that I've summarized in this table here. Causes of EPD. So there are a few causes, it might confuse you, so I have tabulated them in two tables here, two columns here. Anisocoria worsening in dark and anisocoria worsening in bright light. So what does this mean to you? When any anisocoria worsens in the dark, in dark the pupil should dilate, normal pupil should dilate, but when there is anisocoria, that means one is small and one is big. So the bigger pupil is functioning normally because it's doing what it is supposed to do in dark, that is dilate. The smaller pupil which is unable to dilate is the problematic pupil here. So the side which has a small pupil is abnormal in anisocoria, which worsens in dark. So there are only two causes for this, physiological and Horner syndrome. So what is the cause of anisocoria worsening in bright light? So here in bright light the pupils are supposed to constrict. Okay, so whichever pupil is not willing to constrict, that is the abnormal pupil. So I would like to add here old AD's pupil. Okay. Sorry. So the causes for anisocoria worsening in bright light are AD's pupil, third nerve palsy, and use of mydriatic. So let us summarize the pupillary defects. Lesion along the optic nerve of one eye. Total lesion causes an amerotic pupil. Amerotic pupil is nothing but a grade 3 RAPD. In the sense, there is no constriction at all. Total RAPD or APD. It's also known as amerotic pupil because the eye is blind. So if the lesion is here, there is only partial affection of the afferent pathway, and this is known as Marcus gun pupil or an RAPD. So it is still relative. There is some constriction, but it is lesser. Affection of the optic tract will give you Wernicke's hemianopic pupil, which we have discussed in the previous class. Affection of the pretectal area will give you the Argyll-Robertson pupil, characterized by light near dissociation. Okay, Argyll-Robertson pupil is seen in neurosyphilis, diabetes, usually a bilateral condition, characterized by smaller pupils. In aberrant regeneration of the third nerve, you can get a pseudo Argyll-Robertson pupil. Then affection of the efferent pathway here, the damage to the ciliary ganglion can give you a tonic pupil or an AD's syndrome, in which the pupil refuses to constrict and the light and the near reflex are absent. So recognize the type of pupillary abnormality based on the pupillary measurements as depicted below. The size of the pupil in the right eye and the left eye are shown here. In normal daylight, it is 5 mm and 3 mm. In bright light, it is 5 mm and 2 mm. So in bright light, the anisocoria is worsening. So as I said, whichever eye has a bigger size in bright light is at fault. So here we know that the right eye is at fault. There is anisocoria, there is right-sided fault, and in dark light again the left eye is dilating, so left is functioning normally, and when applying 0.125% pilocarpine, there is a no effect. So there is no supersensitivity to pilocarpine. Anyway, so by now we have incurred that it is not an RAPD, right? It cannot be physiological anisocoria, because in physiological anisocoria, even if there is a size, there will be slight dilatation. So from 5 it should at least become 6, and it cannot be physiological anisocoria. Right-sided efferent pupillary defect, which seems right here, and left-sided efferent pupillary defect, no, the left eye is behaving normally. So the answer here is right-sided efferent pupillary defect. So how do we work up for anisocoria? The anisocoria is increasing in dim light, so the small pupil, the eye with the smaller pupil is at fault. That means the dilator muscle in that eye is not working, right? So look for, do a good slit lamp examination and look for how the dilatation is. If the dilatation is good, like when you switch off the light and when you switch back on, the pupil is constricting, the pupil is going back, then it's just physiological anisocoria. Look for any mechanical restrictions like posterior synechiae, and if the pupil looks fixed, it is usually AD's pupil. So in other cases, you instill 4% topical cocaine, and this is a test for Horner syndrome. So again, if both pupils are dilating, you are still thinking of physiological anisocoria. So if one pupil does not dilate, the pupil which is not dilating is the culprit, and we are most probably dealing with Horner syndrome. So anisocoria which is worsening in bright illumination, that means the pupil which is supposed to constrict is not constricting. So why is it not constricting? Either there is a segmental iris palsy which is seen in AD's pupil. So instill 0.1% pilocarpine. If it constricts, then it is AD's pupil, because these pupils have supersensitivity to pilocarpine. If it does not constrict, then try 1% full strength pilocarpine. If it's a third nerve palsy, the pupil will constrict. If it is just the use of a mydriatic, then the pupil will not constrict. There is no need to do a neuroimaging in these cases because it is all local cause. So look for iris anatomy. If it is normal, again you proceed towards Ades pupil. If the big pupil has some sphincter damage or iris ischemia or atrophic patches, then you're mostly dealing with post-trauma mydriasis or siderosis bulbi. Okay, now let's talk about Horner syndrome. Horner syndrome is oculosympathetic paralysis. So where does the oculosympathetic pathway start? It starts in the hypothalamus, descends along the midbrain to reach the cervical spinal cord. Here it's known as the ciliospinal center of Budge, where the second order neurons begin. They come out through the spinal cord and end up in the cervical chain. There is a synapse that happens in the superior cervical ganglion, and the fibers post these are referred to as the postganglionic fibers. Anything before this is referred to as the preganglionic fibers. So the third order neurons now pass along the carotids. So if you see, there are two branches going here. One is the pseudomotor. Pseudomotor is usually refers to the fibers that innervate the sweat glands. They pass along the external carotid, and the rest of the fibers pass along the internal carotids, then pass through the cavernous sinus, enter the orbit, and then they supply the inferior and superior lid retractors and the dilator pupillae. So what are the features of Horner syndrome? There is unilateral meiosis, dilatation of lag of the pupil, mild ptosis because of the weakness of Muller's muscle, enophthalmos, and anhidrosis. Anhidrosis is due to this part. In congenital Horner syndrome, the affected iris is also hypochromic. The amount of pigments are lesser than the other eye. So what are the causes of affection of the first order neuron? Neoplasms, demyelination, lateral medullary syndrome, spinal cord tumors, and diabetic autonomic neuropathy. Second order neuron, Pancoast tumor is the most important cause because these fibers pass along the apex of the lung. So you should be cautious when you are dealing with Horner syndrome in smokers. Fracture of the rib and brachial plexus injury. Third order neurons, carotid dissection, cysts, masses, traumatic intraoral injuries, otitis media, cavernous sinus thrombosis, and cluster headache. Okay, so how do we localize? Even though we can do an imaging, localization still holds good in neuro-ophthalmology. So when you instill 4% topical cocaine in both eyes, there will be dilatation normally. Why does this happen? Because it blocks the noradrenaline uptake. So the whatever noradrenaline is released, it is not taken back by the postganglionic nerve endings. As a result, there is excess adrenaline there, causing pupils to dilate. In Horner's pupil, the adrenaline is not reaching the postganglionic nerve fibers, so there is no dilatation. So now we have just made sure it is a Horner syndrome. The next step is to localize it. So we can only localize if it's a preganglionic or a postganglionic. We cannot localize whether it's a first order or a second order. Okay. So 1% topical hydroxyamphetamine is instilled in both eyes. What does it do? It potentiates the release of noradrenaline at the nerve endings. So in the postganglionic fibers, if there is any noradrenaline, that will be accentuated by this 1% hydroxyamphetamine. So in preganglionic fibers, there will be dilatation because from the C8 or the superior cervical ganglion till the nerve endings, you will have some adrenaline that is normally going. So that will be accentuated by hydroxyamphetamine and there will be dilatation. In postganglionic lesions, there is no noradrenaline at the nerve ending, so the pupils do not dilate. Let's take a question now. A 4-month-old child was operated for a cyst in the neck and which was found to be very close to the right internal carotid artery. After removal of the test, the intern noticed an mild ptosis and meiosis on the right side. So we are probably dealing with the Horner syndrome here. There is ptosis and meiosis on one side. So let's go back to our drawing and see where our lesion can be. So they are saying that the lesion, there was a cyst in the neck which is very close to the internal carotid. So we are probably dealing with the third order neuron or a post-ganglionic injury. Okay. So what happens in post-ganglionic injury? Will cocaine help? No. It will cause dilatation only of the normal eye. So this is wrong here. It cannot be both eyes. What happens when we instill 1% phenylephrine? So as it's a post-ganglionic lesion, there will be a super sensitivity of the nerve fibers. So when you instill diluted phenylephrine, there will be sudden dilatation of the affected pupil. In preganglionic fibers, there won't be dilatation. So the right answer is B. Let's look at the other options as well. The right pupil is smaller, but both pupils dilate equally in dark. No. The right pupil will have dilatation lag. 10% hydroxyamphetamine eye drops causes dilatation of the right pupil. So amphetamine can cause dilatation of the preganglionic lesions only. So this is also wrong. So the right answer here is B. I hope it's clear. Amphetamine and phenylephrine are different. Amphetamine will cause dilatation of preganglionic lesions and 1% phenylephrine will cause dilatation of the postganglionic lesions. Okay. Which of the following is false about AD stonic pupil? Light reflex is absent but near reflex is brisk. No. It is an EPD, so it cannot have a brisk near reflex. Both the reflexes are absent. Can see vermiform contractions along the pupillary margin. Yes. It's due to the destruction of the ciliary ganglion. Yes. There is supersensitivity to 0.1% pilocarpine. Yes. So AD's pupil is a big pupil. The light reflex and the near reflex both are absent. So when you see in the slit lamp, you will see worm-like constrictions along the pupillary margin, and it can be associated with a syndrome called as Holmes AD syndrome, which is characterized by an absent patella jerk, and also it is seen more commonly in women. So this is about AD's pupil. So the only symptoms you can get in AD's pupil is some amount of glare due to a big pupil. Answer is A. So what are the causes of AD's pupil? Viral ganglionitis, diabetic peripheral neuropathy, Holmes AD syndrome and alcoholism. What is an incomplete Horner syndrome? It consists of all of the following except meiosis, mitosis, enophthalmos and anhidrosis. So an incomplete Horner syndrome is when there is affection of the sympathetic fibers along the internal carotid artery. So the pseudomotor fibers which supply the sweat glands have already left and they are supplying through they are passing along the external carotid artery. So anhidrosis is absent. So it's usually seen in ICA dissections. It is known as incomplete Horner syndrome. So how do you objectively quantify anhidrosis? We do something known as a Victor Minor test. Here the tincture iodine is applied over the forehead and some corn flour is used to dust the tincture iodine. When there is sweat, so you can induce sweat by asking the patient to perform exercises or raising the temperature of the room. You will see that sweat mixes with the tincture iodine and there is a change in color. So if there is a change in color on one side, that is anhidrosis is not there. So in the sense, whenever there is anhidrosis, there is no change in color. Whenever there is sweating, there will be a change in color of the iodine. So this is the Victor Minor test, useful in objectively quantifying anhidrosis. So that's all for today. Let's meet next week for the next class. Thank you.